Heart failure.
Heart failure, they can do that. But usually people with high salt content, the salt will cause you to retain water. And so what will happen to your blood pressure? Will it go up or down?
Oh, hypertension.
Right. So yeah, we're going to minimize excess salt so we can decrease high blood pressure.
Okay.
And if we don't treat high blood pressure, all the things what you said was true. So if we don't treat the high blood pressure, then we can end up with heart failure. So that part is true as well. So you were on task. You just had to get to the cause of the matter, if that makes sense. Okay. So do we normally make cholesterol in our bodies?
We do.
Okay, we do. And then we also get it from animal fat, right? We get it from eggs and meats.
Okay. Yes.
Dairy products. But now the part you were saying previously, high cholesterol causes
heart attack.
Heart attacks, exactly. So it can block the vessels. They can also have a stroke. So there's a couple things that can go on there. I think somebody has their, we're not talking, if we can mute the, yeah, because I hear little babies in the back.
Oh, I thought.
Unless you were talking, that's what I was saying. So what about the fats in the food? They have calories. That gives us energy. And where can we get our healthy fats from?
Is it complex carb? I'm sorry. Is it complex carb or no? Healthy fats?
Our healthy fats. They're usually in certain oils.
Oh, like olive oil,
avocados.
Your fish oils, your nuts. Those would be the place. That'll be the place where you would find that, right? So if we have now some folks, like if you eat a steak and the fat, the trimmings that's around the steak, some folks really love to eat that. So that means that can cause weight gain, high cholesterol, end up with heart problems as well. So some of that you want to have kind of trim the fat versus have all that fat on the steak. Read labels. So we should have some healthy oils at least, 2 times a week. So salmon, tuna. What type of salt intake should we have? How much salt should we take in per day?
Like with 2 grams?
So less than 2,300 milligrams.
I'm sorry, ask the question again.
So the question was how much fat should we take in? I mean, sorry, not fat, salt. How much salt should we take in per day? And the response was 2 grams. So less than 2 grams, 2,300. I mean, 300 milligrams, I'd shave that off, but still less than 2 grams of salt you should have. Okay. Then, other things we can substitute it with is the spices and seasonings like Mrs. Dash. Hang on a second. Miss Kim, can you mute your phone? Just mute it. Don't leave, but just mute it. Thank you, babe. All right. Your cholesterol, the amount of cholesterol that you take per day, how much should that be? How many grams of cholesterol should you have per day? It should be less than 300 milligrams per day of cholesterol. So that's why your lean meats and fresh vegetables, that's why you want to have that. Okay. What about trans fats? Should we look at that? Trans fats. Should we have a bunch of trans fats or should we limit our trans fats?
limit trans.
We should limit our trans fats, okay? So your book kind of gives you a list of things that you want to monitor, or you want your patients to monitor, but you want them to have high fiber, like whole grain breads, making sure they're getting plenty of fruits and veggies, either low fat or fat-free dairy. We get our protein from things like chicken and turkey, fish, beans, things of that nature. So where do we want our HDLs to be? Our lab values. HDLs are the high density lipoproteins.
$50 or higher.
So greater than 60, that'd be 60. And the HDLs is inversely related to cardiovascular risk. What does that mean? When you say it's inversely related. So if one is up, then the other one is down. So that'd be the inverse relationship. If it was a direct relationship, then when one's up, the other one's up. So when your HDL numbers are high, so say, which would be fine, it's no big deal. It's when our HDL levels are low that it's a concern, but the higher the HDLs, the less cardiovascular risk the patient has. The lower the HDL, so when it's 30, then your cardiovascular risk is much higher. Now the LDLs, the lousy, or they're really called low density lipoproteins. However, we call them the lousy ones, and the HDLs, the happy ones. But the low density lipoproteins, they are directly related to cardiovascular disease. So when that LDL is elevated, your risk factors are elevated. So what's normal for your LDLs? Less than what?
100.
Less than 100. So that's where we want it. If it's between 130 and 159, then you're kind of borderline for cardiovascular risk. 160 to 189, those are high levels. And then if it's over 190, then that's extremely high. So hopefully no one has that. Your total cholesterol is directly related also to your cardiovascular risk. So the higher your cholesterol level, the higher your cardiovascular risk. So anything less than 200 is where we want our cholesterol levels to be. So when it's 200 to 239, you're borderline for cardiovascular disease, and if it's greater than 240, then you have a high risk. We also have triglycerides, which is the main storage of lipids, which is fat. So it's 95% of the fatty tissue. And we use it to screen for high lipids in the blood. And we also use it to screen for pancreatitis. So your borderline, if it is between 150 and 199. So normal would be less than 150. BMI, what's normal?
Less than 25.
So between 18.5 and 24.9, so less than 25. Overweight's between 25 and 29.9, so it's a narrow margin. And anything over 30, you would be considered obese. So if you have greater than 30 BMI. If you're less than 18.5, you are underweight, okay? So just kind of a review of all the nutritional stuff that that was a couple weeks back, so just kind of refresh memory. So who's looked at the malabsorption? Because that's also on the test. I didn't talk about it, but we didn't have time, but I just wanted to make sure I circled back on it on the Zoom session. What is the reason why folks develop malabsorption? What are some causes?
Can it be celiacs?
So celiac disease, absolutely. Certain antacids can do it. phenytoin or dilantin when it's used on an extended basis. Pancreatic disorders, so like cystic fibrosis, pancreatic cancer, damage to the GI tract from radiation therapies, so that would be part of the cancer process. Hookworms, so parasites, someone with pernicious anemia. So what kind of happens with, with someone with malabsorption? What's really going on? What is it that they can't absorb?
Nutrients.
Nutrients. So the normal digest, what happens is that the mucosa of the small intestines can absorb the nutrients that are efficiently. So sometimes it may affect the amino acids absorption. It may affect the fats absorption or the vitamins absorption. So they have an inadequate movement of the nutrients in the small bowel, so that doesn't make it to the bloodstream or it doesn't make it to the lymphatic system. But a diet that's, high in gluten, so like in whey and barley and rye, it becomes kind of toxic to the patient, causing injury to the little finger-like projections or the villi, right? What about lactase deficiency? What does lactase do? So lactase causes, or if it's a lactase deficiency, then it's already in the gut enzyme or the intestinal. It is an intestinal enzyme, not in the gut, but it is in the gut, and so it prevents it splits the non-absorbable lactose into an absorbable sugar. So, now we have another issue. What about bacterial growth? Will that be an issue with malabsorption? And if so, what's not being absorbed? Intrinsic factor is there, isn't it? Don't we have intrinsic factor in our abdominal cavity or in our intestines? And it's responsible for our B vitamins, specifically B12. So if we have a bacterial infection, then we're going to lose the ability of B12 to be absorbed. So there's a list that's provided in your textbook of all the different risk factors: radiation, family history, defects of the gallbladder, certain medications, ethnicity. So or not necessarily ethnicity, but if you travel to Asia or to the Mediterranean or the Caribbean, then you can have issues. All right. What labs do you think you need to do? What kind of labs? So usually if you're, go ahead, what was that? If folks that are gluten intolerant, what kind of problems do they have if they're gluten intolerant?
You're gonna have stool, diarrhea.
So watery diarrhea quite a bit, and it could be pale or stinky or bulky, so steatorrhea, a lot of gas, dry skin. Those would be some signs and symptoms. So if you have a lot of diarrhea, we probably should send that to the lab for, to see what's going on, to look at the fat content, to help see what's, how much is being excreted. Anything else? What's the test that tells you if they have a vitamin B12 deficiency or absorption of deficiency? Starts with an S.
Chilling test.
That'd be the Schilling test. So we want to look at a CBC to see if they have any type of anemia, because that's a cause. Protein levels, our serum protein levels. Anything else we could look at? What type of electrolyte imbalances would a person that has malabsorption, what would they experience?
It would be low.
Which electrolytes? You're right, they're going to be low. But I want to know, there's 3 electrolytes.
Is it low potassium or calcium?
Potassium, calcium, and magnesium. All 3 of those are going to be low. And having a low potassium level isn't good, because now you can end up with arrhythmias. Okay. What type of diagnostic studies could you do?
You could do an upper GI.
Okay. An upper GI series or a barium series?
You're asking it's either one, or I'm sorry.
So
Are
the
you-
question was, what kind of diagnostic studies could you do? So she said an upper GI X-ray, or are you looking at are you looking at an endoscopy? What are you looking at?
Endoscopy.
Okay, so an upper GI endoscopy or endoscopy, that'll be one. You could do a biopsy while you're there, see what's going on. You could do an ERCP. What's an ERCP?
It's something with red blood cells.
Now, this is a diagnostic, like an X-ray type of thing, where you can look at the pancreas, you can look at the biliary duct. Say that again. It's a big, long word. Endoscopic, retrograde, cholangiopancreatography.
Oh,
That's what an ERCP is. So endoscopic retrograde cholangiopancreatography. Then you could do a barium study, so you can look at that, or you could do CT of the belly and the pelvis. So there's a couple things you can look at. Medications, what are we going to give them?
So they'll probably need some supplements of the calcium and magnesium.
Okay. The iron, they'll need that if they have anemia. We just talked about how if they have a bacterial infection, that the B12 won't absorb, so they may need B12 since they have malabsorption issues. If they're lactose intolerant or lactose deficient, then they're going to need some lactate. If they do have an infectious process in the abdominal cavity, then we're going to give some antibiotics. And then to decrease the inflammation, then we're going to give some corticosteroid. So do you remember what I've talked to you guys about with the corticosteroids? And if a patient's on corticosteroids and they have any type of stress, do they need to increase or decrease their dose?
That's what Tracy heard you talking about last night. Guy drove down a half dozen shark shoes because all he wants is to die.
Say that again. I didn't hear you. You're on mute. So if you're talking, you got to unmute yourself. So if you're on corticosteroids and you have any stressors, then you're going to have to increase the dose. So, because you're going to kind of go through that. Okay. All right. Anything else you can think about for malabsorption? All right. So what about babies? You have failure to thrive, right? Give me some things that you can do as a nurse, you know, when you're doing interventions and you're getting ready to discharge the kiddo. How do you know, first and foremost, if babies are failure to thrive, let's go back a little bit so we can get to this piece. If babies have failure to thrive, are they eating? Are they getting all the nutrients that they need?
No.
No. So, you know, we want to try and give them a routine. And then besides, you know, something liquid, what can we give them to give them the vitamins that they need?
Is that where you would do the polyvisol?
Yep, you would offer some type of multivitamin supplement that will, you know, help facilitate the things that they won't be intaking from food. So should we give them juice? You know, offer them some kind of juice? And if so, why?
Would it be because they're at risk for hypoglycemia?
So actually, if they're less than 6 months, no juice.
Right. Okay.
So they should not get any juice if they're less than 6 months of age. It's actually restricted from the diet. And a lot of that, the juice is high in sugar content, which is, you know, we're trying to build nutrients, not, you know, dehydrate them. And some of those things can send you to the bathroom. If we feed them cereal, should it have iron in it? Yes or no? So basically, should the iron or should the cereal be fortified with iron?
Yes.
Yes, we need to give them iron. So if we're giving them polyvisol, we have to also be giving them iron, because if they're not eating, then they're not getting those things as well. Should you give them extra water to you know, keep them hydrated?
No.
Nope, because what we can do there is actually cause water toxicity. So we don't want to give them any type of water. And it doesn't have any caloric intake anyway. So then it will prevent, if you give them water and they get full on water, you may not be able to feed them afterwards. So we don't want to do the water thing. Okay. So what is the difference between organic and inorganic failure to thrive?
Organics where they actually don't have any feed, while inorganic would be an underlying cause, like a disease.
Okay, like what? I'm sorry. And the reason why I asked that is, it's one thing to know it, but if, you know, so say they give you a disease condition, would you be able to recognize that this was, you know, from that cause? So that's why I'm saying like what? So not to, you know, bust your chops or anything, but just basically, it's one thing to know it, but provide some example to it would be perfect.
So hyperthyroidism.
Okay.
Because it'll be hypermetabolic, so they'll be burning through all their excess feed. If they eat more, they still won't be able to keep up.
Okay. You guys agree? Or you're like, oh, I'm just glad somebody spoke out. Is that what you're saying? Yay, nay, you're still thinking.
What about like a heart defect?
Okay, how would that work?
I don't know.
Things that, what about like developmental disability? So if they have a mental or physical impairment that's lifelong, that could contribute to failure to thrive, because now their ability to intake food or nutrition is impaired because of their sensory and motor delays. So like cerebral palsy. Organic causes would be like inability to suck and swallow correctly, malabsorption, diarrhea. So alterations in metabolism and their caloric needs and intake. So if they have chronic illnesses, chronic lung disease, cleft palate, that'll be difficult for them to swallow because they have that hole, right? So those would be some of your organic causes. Neglect and abuse. So lack of appropriate interaction from the parents, haphazard feeding, so poor feeding techniques. Parents' knowledge base is lacking or is lacking. So things of that nature. Poverty kind of brings that bring that about to the forefront. So, there's a lot of different developmental issues that can bring about a kiddo having failure to thrive. And then, the maturity level of a parent having children, you really have to have the mindset for it. So if you're just, I just want to have a baby and see what it feels like to have a baby, the mindset's not there, right? Maybe still thinking about it. So, those are some of the things to, consider. It could be financial. That goes back to poverty. Or they live in a food desert. What's a food desert? And it really isn't like what it sounds either. It's not like the food's lacking. Well, food is lacking, but it's nutritional food that's lacking. But all of the fast food places are there in full bloom. So that would be that situation there. So, go ahead. You were saying something? Okay. So things you want to look at, will they have the appropriate weight gain? Would they be height and weight proportionate? Would their head circumference be within normal limits?
No.
No. So all of those are things that are going to be underweight. They may have a larger head. All of those things could be potential issues. Their interaction between family members and caregivers, what happens during the feeding time. We want to make sure we have them on a regular schedule. So we're going to get a routine going. Those things help to manage your failure to thrive kiddos. Make sure we give them the right amount, or we feed them like we're supposed to, weigh them every day. Are we going to do strict diagnose?
Yes.
Strict diagnose. And then we want to give the parents support, because, sometimes if they have a developmentally delayed kiddo, that's going to be very stressful and taxing on that parent, right? So now they need support. So support groups and things of that nature would be good. So what are your thoughts? Y'all have a thought? Somebody have to have a thought besides me.
Would the babies have like a larger abdominal girth due to malnutrition as
Well,
well?
their bellies are already big, but they
Mhm.
could have like a bigger belly.
Okay.
And you see that with some of the I think it's the Cambodian babies.
Mm.
So that non-organic stuff is, that's where they have a decrease in their physical growth or a downward turn in those percentiles. So that could be poor emotional functioning, poor development. So there's a lot of concern there. How do you know that a baby is failing to thrive? Are they very active? Do they interact with their environment really well?
No.
They don't, and they tire out easy. They're really sleepy. They don't make eye contact. They don't make vocal sounds. So, they don't really mold with the mother well. So those are all different types of signs and symptoms that would let you know that a patient has failure to thrive. Okay.
Mhm.
All right. So yeah, structured environment, to reinforce the feeding, encourage the infant to be held, with the mother. We don't want to just give the baby the bottle and be like, here, hold this for yourself. We're trying to interact with the kiddo. Does that make sense? Do we want to have a set of different caregivers for this kiddo?
No.
Nope. So we want to have a team of caregivers, but we want those caregivers all to be the same team. So say if there's a team of 4 nurses that's working with the baby, then we don't want to bring in a set of new nurses. So we want to minimize the number of caregivers so that way you're promoting consistency. So we want to make sure we have that consistent structured environment. Okay. So let's move on from, I think that, what about tube feeds? That was another one we didn't talk about. There's different types of G tubes. So you have a nasal gastric tube, you can have a jejunostomy, a duodenostomy. So there's different ileostomy, different places of where they can put a G tube. So if you're doing like a nasal gastric tube, how do we check placement for that?
Is residual. You do have a certain amount of residual.
We're looking at residual, and what should that residual be less than?
Isn't it like 50 cc's?
I think it's a little more.
Like 75, 100.
It's around 100. So it's up there. So you want to make that's actually tolerable or okay. That's one thing before you put some more tube feed in, right? But before we get to the tube feed part, we just put in the nasal gastric tube, and how do we know that
An
it's in its
X-ray.
proper place?
Chest X-ray.
Got to do a chest X-ray. That is the gold standard. So there's no longer the inserting the air and then, you know, auscultating over the stomach to see if you hear it. That's long gone. So now we need to get a chest X-ray. That's our gold standard. Okay. So there's different ways to infuse tube feeds, but we want to make sure it's going in. What if it gets clogged? What can you do?
You can flush it.
So I'd probably try to aspirate and then flush it. So I can see what's in there, make sure it's not, you know, any blood or anything like that. So we can flush it. Those are options. Okay. What about, go ahead, what was that? I thought you were saying, somebody was saying something. Okay, so, trying to see what else about the G-tube. I think that was it. I don't think there was anything else extra about the G-tube that I can think of. If so, I'll come back to it. It's no biggie. Okay. What I think we have is one of your exemplars, GERD, that falls underneath that as well. Would that be correct?
Yes.
Okay. So gastroesophageal reflux disease. Why do people have GERD?
Different imbalance of stomach acid and within the gut.
Okay,
like-
but why? What is the problem? You know, how do you develop GERD? I mean, not you as a person, but how would a person develop GERD?
Spicy food.
What's the dysfunction there?
Weak
I hear dishes being washed. Okay, let's try this again. So how do people end up with GERD? What's the problem in the GI system?
The esophagus?
It's part of the esophagus. Which part?
At the lower esophageal sphincter.
The lower esophageal sphincter is you know, dysfunctional. So you end up regurging back that stomach acid. So have you ever, you know, belched and then like your whole throat was on fire? That was a regurge of coming from your stomach. That stomach acid is the part that you're like, oh my gosh, you know, and it feels very acidic. So they're having that heartburn type feeling, correct? Which is not the norm. So I mean, what's your signs and symptoms, and then how do you treat it?
Very painful.
Okay. It is painful. How do you treat it?
You can treat it with diet.
Okay, you can.
True.
Go ahead.
Proton pump inhibitors.
Proton pump inhibitors. Okay. So basically, we got a backflow of gastric content or even duodenal contents. It can even come down from that far. And the lower esophageal sphincter is incompetent for whatever reason. Or you could have a hernia there, it could be a stenosis, or it could just be a motility problem, right? So there's other things. like patients that are COPD, they tend to have GERD as they get older. Peptic ulcer disease, that. So it can be associated with smoking, nicotine, caffeine, alcohol consumption. Those are all things that can bring on GERD. So heartburn is usually the most common cause. So it's like a burning sensation in the esophagus. Indigestion or dyspepsia, dysphagia, or they're salivating a lot. So people think they may be having a heart attack because it's like in the center of their, like right at the base of the sternum. Because of that acid being, and if it gets to the mouth, they can end up with, you know, breakdown or decay of the teeth, ulcers in the pharynx or in the esophagus. So there's a lot of complications that can happen related to GERD. So it's not something, you know, super simple. How do we diagnose GERD? What's the diagnostic test that we may use?
Is it the barium swallow?
It is a barium swallow, or they may do an endoscopy. So either one of the two. How we're going to manage it? Low fat diet. So if alcohol, caffeine, and tobacco, if those are causative agents for GERD, then those would be the things to avoid, right? So stay away from the beer, Patron, and all of those things. Avoid milk or foods that have peppermint or spearmint. Sodas, you don't want to be drinking those either. Small, frequent meals per day. And should we eat within 2 hours of going to bed?
No.
No. So 2 hours, you need to eat like earlier on. So if it's with it, you go to bed at 10 o'clock, don't eat anything from 8 o'clock on, okay? Keep your bed up at about 30 degrees. So yeah, those are some things to kind of monitor. Then we can use, you know, things like antacids to help minimize, you know, the gastric acid in the stomach, so that we can suppress the acid that's there. And when you do have GERD, what about that protective layer? Do you lose that, or what happens from all that acid being in your stomach? Do you lose the acid? Yes or no?
Yes.
Yes, you lose, well, because of the acid, you don't lose the acid, you actually lose the protective layer is what ends up happening. So you lose that protective layer, having all that acid being in the stomach. So that's why an antacid like Tums or Malox, that would be great. But when you've lost that protective layer, then you also lose, you also put yourself at risk, or the patient's now at risk for C. diff or an infection. So we give them H2 blockers or histamine 2 receptor antagonists. So a blocker and an antagonist are the same. So that would be like your Zantac, your famotidines. It'll be all your deans, your famotidine, your ranitidine, your cimetidine. So all your DINEs are your H2 antagonist. So here we want to monitor for QT interval prolongation in your patients. We want to dilute the medicine with some normal saline before we administer it. And how fast do we push that? How fast can we push an IV push? For a non-critical cardiac arrest patient. So any IV push you should do over at least 2 minutes. 2 minutes. So we also have our PPIs, our proton pump inhibitors, and those are going to be all of your prazoles, P-R-A-Z-O-L-E. So anything that ends with prazole, like pantoprazole, omeprazole, lansoprazole, all of those are going to be your proton pump inhibitors. So your Protonix, your Pralisex, your Nexium. Your Nexium is esomeprazole, your Prevacid. All of those are going to be your PPIs. Okay. So they're going to help with the ulcers, help to decrease ulcers. They're going to inhibit the proton pump, which actually releases acid or hydrogen, and hydrogen is an acid. There's, I think, sucralfate or carafate. So that kind of coats it's like a pink tablet. You put it in water and it turns pink, but it's like a little slurry. So it kind of coats the stomach lining to help, you know, minimize the acid damaging the stomach mucosa. Okay. So they may have to get an endoscopic resection. They may have to use, you know, radiofrequency ablation. So there's a lot of different treatment management, but it starts off fairly simple. They start with diet, so eliminating some of those causative agents, and then going on to, you know, some more advanced things to do, like medications and things of that nature. All right. So if you have a patient that has GERD, so key things is making sure we don't, you know, have them eat within 2 hours of going to bed. They keep the head of the bed elevated. They don't smoke, drink, or have things with mint in it, like peppermint or spearmint, because that's going to amp it up. And what I mean by amp it up, it's not going to make it's not going to help the GERD diminish. It's actually going to increase it. Okay. All right. So if a patient has type 1 diabetes, can they exercise? And if so, do they need to consider anything? Type 1 diabetes.
Yes, they can exercise, and they should consider either doing eating a little bit more of a snack beforehand,
Okay.
or they could do a smaller dose of insulin.
I don't know
Because
if
if
you
they're
want to
gonna
do a
have,
smaller dose of insulin, because if
they'll
you,
just eat more.
yeah, you need extra snacks. So because exercise decreases the glucose level. So, you know, we don't want to take less insulin, because then we may have another problem later on down the line. So whether you're a child or an adult, if they exercise, then they need to bring along some extra snacks. Okay. So that way they can keep their blood sugar level. I was trying to think of the words, like, what am I trying to say? So, all right. So you have, what about, let me ask another question. What is the complication of type 1 diabetes? DKA. So does the number need to be super high to get DKA, or is it about the formation of ketones? It's about the formation of ketones. So if they have type 2 diabetes, how do we treat that first? Now that we switch to type 2.
Diet?
Diet and exercise. That's where they're going to start. And if diet and exercise isn't cutting it, then they're going to continue with the diet and exercise, but now they're going to add in a medication to help treat that. So some other complications they can develop from diabetes is micro and macrovascular complications. And so to prevent a patient from developing macro and/or microvascular complications, what should we do? How do we manage those folks? What's the best way to eliminate or minimize getting the microvascular or macrovascular problem?
Keeping the blood sugar under control.
So control the high blood sugars, because remember, even when you have diabetes, you have delayed wound healing. So everything takes more time. Even if you get the flu, it's going to take you more time to heal. So if you control the blood sugars, then that actually helps to assist in your healing. Does that make sense? So it helps the wound to heal better, because now we don't have all this extra sugar that can cause extra bacteria to grow. Okay. And if you're stressed, if you're an adult and you're stressed, let's start there. Does your blood sugar level go up or down?
Up.
It goes up. If you're a kiddo and you're stressed, then your blood sugar level actually goes down. So, and that stress could be family, it could be an illness, but it's going to, cause the blood glucose to be released, and we're going to end up with more blood or more sugar in the blood, for lack of a better word. So yeah, if we control the blood sugars, we can control, wound healing and things of that nature. We can also control in-organ disease processes as well. So the macro and microvascular problems or complications. So what is the blood test or laboratory test that they use as the best indicator to manage diabetes?
A1C.
Okay, so what's the other word for A1C? Because I told you there was a couple ways that they say it.
The HbA1c.
So hemoglobin or the glycosylated. So there's 3 different ways. Some say A1C, which it should be less than 6.5, really less than 7. Or they say hemoglobin A1C, or they say glycosylated A1C. So you need to, be aware of all methodologies. So if we get, when will the glucose actually spill over into the urine? What level would the glucose need to be for that to happen?
Higher than 180.
180, okay. So what if this is a female that is pregnant? What's the concern you need to look at now?
The gestational diabetes.
If they have gestational diabetes, so they're going to do that glucose tolerance test, right? And usually if they develop gestational diabetes, it's because of the hormonal changes that happens during pregnancy. And there's a 50-50 chance that they may develop it later in life. Depends on how they manage their diet and exercise. All right, cardiovascular wise, what are some things that you can change? What are modifiable risk factors? That's the word I'm looking for.
Diet and exercise.
Diet, exercise, okay. What about diabetes? Is that considered to be a modifiable treatment?
Yes.
Yes, it is. So I can't change my gender via chromosomes. You can't. I can't change my age, but I can decide to not be sedentary. I can eat healthier. So those are things that I can change. So, those are some allowable things. What would be some concerning history that you may hear from a patient? you know, like especially if they're males. And this is still in relation to cardiovascular disease.
Hypertension.
I'd be more concerned if the hypertension wasn't treated or if it was extremely high. But in relation to coronary artery disease or cardiovascular disease, what if the patient's uncle had a heart attack at 50? Would that be something to be concerned with?
Yes.
Yes. So for men, unfortunately, if you have that cardiovascular history, it is on the gene. So if your uncle has a heart attack at 50, your dad will more than likely have a heart attack around the same age, if not younger. And you, as a male child, would actually have a heart attack around the same age, if not younger. So you can be 25, and if you have that in your genetic gene pool, then you can end up 25 and having a full-blown out heart attack. Okay. So, you know, diet can help improve the lipid levels, make the LDLs go down and the HDLs go up. Is that what we want to see?
Yes.
Yeah. So if we're you know, doing a care plan for a patient, we want to make sure we're focusing on you know, if they have high levels of the LDLs, and then we want to talk to them about decreasing, you know, ways to decrease the low density lipoproteins. So give me some foods, some nutritional things that we can use to lower the LDLs.
Avocados.
Okay.
Fish.
Fish, okay. What about green leafy vegetables? Would that help?
Yes.
Absolutely. Green leafy vegetables, complex carbs, fresh fruit. Those would be things that could help decrease the your LDL numbers. What about red meats and simple carbs like fruit juices and candy?
No.
Nope, they won't. Okay. So whole milk and red meat and your simple carbs, nah, it won't. Or that won't. Trying to see what else about CAD before we switch gears to something else. While I'm talking about nutrition and lowering things, and this is a flip flop, and I apologize for that because I'm trying to follow them all in order. So we talked about the celiac disease, right? And we talked about some dietary stuff. So what type, we know that they're intolerant of proteins that are found in grains, like the wheat, the rye, the barley, right? But what things can they eat? Can they eat potatoes? What can they eat? For folks with celiac disease.
They can have potatoes, rice, vegetables, fresh fruit.
Okay.
And some meats. Just no gluten.
Right. Definitely want to stay away from the gluten. So You know, your book talks about foods that contain gluten and, you know, things that they need to stay away from. So no cake, cookies, and pies. They don't need any of that. Breads or pasta, modified starch made from wheat, none of that. And there's some things they should use cautiously, but they can have corn. They can have that. So they can have corn. They can have fresh veggies. What else can they have? So what else can they have? What kind of foods? Can they have corn? Can they tolerate corn?
They can have tequila.
No, how's tequila gonna help them? They can have, did you say, what did you say? I want to make sure that I heard that right. Did you say tortillas or did you say tequila?
I said they can have tequilas and wine.
Oh, I was like, tequila? So yeah, what kind of foods? They can have corn. They can have that. That's not a way.
Soybean.
They can have potatoes. They can have potatoes. They can do that.
Meats, fish, fresh fruits.
And fresh fruits. So you make sure you don't get stuck just focusing on certain things. So this is kind of why we're going through to make sure we're touching all pieces and not just a handful. Okay. All right, so let's look at, so are we good there? All right. Nutrient dense. What is it to be nutrient dense?
You said nutrient dense?
Mm-hmm.
Foods that's high in nutrients.
Okay. It's kind of a reuse of the word. Can you expound on that?
Is that like the complex, like
lean meats.
Okay. So when someone says, hey, you need to have a nutrient-dense diet. So basically we're looking, it's the level of nutrition that they have to a specific volume of food. So if it's nutrient dense, it is going to have a lot of nutrients and fewer calories. Does that make sense? So now when it's nutrient dense, those are more nutritious. It has the least amount of calories. Okay. Now the question for you is, what foods have the best nutrient dense elements?
Complex carbohydrates.
I want something a little bit more specific. You're like, well. She's like, he said, and she grunted at me like,
Oh, like
I know.
like whole grain breads?
Would whole grain bread be the best? No, we're talking, remember, it's more nutrients and less calories. That's what nutrient dense.
So like vegetables.
So fruits and veggies, that's going to be your best nutrient dense category. Okay. Yeah, fruits and veggies. She was like, ooh. I'm sorry, I just found that to be a little hilarious. All right. Tell me foods that are considered to be clear liquids.
Broth.
Okay.
Apple juice.
Apple juice. Okay. So basically, when they say clear liquids, they are clear at room temperature and body temperature. So broths, bouillons, ice pops, any juice that's clear like apple juice. Some carbonated beverages like, well, you guys use Sprite. In Connecticut, we use ginger ale. So things that don't have the cream, don't use cream in it, so regular beverages, whether it's caffeinated or not, that doesn't use a cream. Certain teas, so that would be your clear liquid, so like a popsicle, Diet Coke, bouillon cubes, but if it has a creamer in it, it's out immediately. Gelatin's another one. That's another clear liquid food. And then you have things that are full liquids. And full liquids, they have all the same things as clear liquid, but they include milk in it. So that's what makes it a full liquid, is when they add milk. Or refined cooked cereals, but that'll be milk, like oatmeal. Vegetable juice, that's a full liquid. Clear liquids are things that are clear at room temperatures, like your jellos, your bouillons, your carbonated beverages, your popsicles. So look in your Taylor book, Tayler, or not YER, Taylor. It gives you some really good things. All right, so what about someone who's dehydrated? So if you have a person that's like an elderly individual that's dehydrated and they've lost 15 pounds, 20 pounds, is that significant?
Yes.
Okay. So they're telling you, you know what? Food just doesn't taste like it used to. What are some things you can do to improve their nutritional intake? So they don't have a problem swallowing, they can swallow. So what things can you evaluate? What intervention could you use to, get them interested in food?
The salt shaker.
What would the salt shaker do?
Generally, it makes it more appetizing. Get a lot of salt as well.
Well, interesting. Okay. Oh, you saying if they add salt to the food, but if they're already dehydrated, would that be the right thing to do?
I was gonna say for dehydration, or if they're on food restrictions, it won't help.
Okay. All right. So what about seeing if the client's depressed? I mean, maybe they're depressed and that's the reason why they're not eating. Or maybe, this could literally straight legit be me. If you're serving food that I don't like, I'm not going to eat anything. So, maybe maybe the food choices is not what they like. So, maybe have them, bring up some other menus. Sitting up for meals to help, facilitate better chewing and all of that. And then maybe doing some oral care before and after they eat. So some of those things could probably help. the individual with better nutritional intake. Just kind of some food for thought there. Let's talk a little bit about, we've covered almost everything. We talked about GERD, we talked about celiacs, we've talked about malabsorption. We didn't talk about hyperthyroidism. What are signs and symptoms of hyperthyroidism?
Goiter,
Goiter.
anxious,
Mm-hmm. So if
edema.
I have hyperthyroidism, then that means that everything is elevated. So my heart rate's going to be up, so I'll probably have palpitations. I could, if I have like Graves' disease, I could have the protruding eyeballs, right?
Mm-hmm.
I would be nervous. I'd have weight gain or weight loss.
Weight loss.
Weight loss. Since I'm producing all this extra heat.
Heat intolerance.
Heat intolerance. I'd probably be sweating. I may be irritable, unable to sit down or be quiet. Flushed skin. So those are all the signs and symptoms that I may experience. So on the other side, I could have hypothyroidism. And if I have to take medications for it, either one, can I stop them when I want to?
No.
So this is going to be lifelong therapy. Okay. So it's going to be lifelong therapy. What is Graves' disease? Is that hyper or hypothyroidism?
Hyper. So autoimmune. Autoimmune.
So we can now treatments. What can we do? Give them some anti-thyroid medicine. We could give them iodine. Exercise, large muscle group exercise. And then they could potentially have surgery, or we can use the radioactive iodine. So those are all part of the treatment plan that could be done. How long? So if a person just gets diagnosed with hyperthyroidism or Graves' disease, something like that, how long will it take the medication to work? A day, 2 days, a week, several weeks, 5 months, what?
Several weeks.
It's going to take several weeks. So they need to know that those symptoms, it's not going to stop because they just pop a pill. It's going to take time for them to get built up in the system. The other thing, if you're diagnosed with they're trying to diagnose you with hyperthyroidism and do a thyroid scan, what's going to be the concern there? That you need to make sure you get as a part of your history from your patient. So when you do a thyroid scan, what's involved in that would be something that you would ask in your patient's history?
Contrast?
They're going to use some type of radionucleotide dye. And that dye we need to think about assessing for allergies. So it is contrast dye. So you're right about that. So if
Is it the same? Is it the same kind of dye for thyroid studies that they
like
that
CT
cleared in the
scans and stuff
kidneys?
like that.
Yeah.
And although this is radionucleotide, and remember some of that is radio, it glows under X-ray. So you want to look for shellfish or iodine allergies. You want to eliminate allergic reactions. So we want to assess them for that on the scan. We want to ask them, do they have any allergies to dye? And people may not know if they're allergic to dye, so then you got to come back with shellfish or iodine. Okay. If your client is malnourished, because that's another part of the exemplars we have, then, and they have a wound, how does malnourishment and wound healing, what's the connection there?
It's going to take longer time to heal.
It's going to take much longer for it to heal, just no different than diabetes. So they need to have that extra protein to promote healing, because protein does promote healing. What if the person, and this is part of diversity, what if the same client, the day that they're kind of refusing not to really eat is a religious holiday for them? Do you make them eat anyway?
No.
No. So, you do tell them that it's beneficial to eat, but if it's a religious holiday and they have to fast or something like that, then So, all right, so let's look at some thermal regulation. What types of, let's see, what is the concern with thermal regulation in kiddos?
That they don't shiver and they can't regulate their heat very well.
Why can't they?
Because they don't have a lot of brown fat.
Why is that? They do have the brown fat which is highly vascular, but it's found only in newborns. So it can convert chemical energy into heat when activated. So it's not the brown fat. What is it? Where is our thermal regulatory system?
Hypothalamus.
The hypothalamus. So in an infant, is that
it's underdeveloped?
It is underdeveloped. It is immature. Okay. So now my question to you is, what would be a risk factor for this to be even more significant?
Underweight.
Low birth weight and or
prematurity.
Well, the thermoregulatory system is immature. So that's hands down in any newborn. But if it's a low birth weight newborn, it's worse. And if it's a preemie, it's worse. So look at it this way. if I'm a kiddo and my thermoregulatory system is immature, if I'm not even to term, it's going to be even more immature than what I was if I was term. Does that make sense?
Mm-hmm.
So
Yes.
your preemie babies and your low birth weight babies are at a higher risk of hypothermia. Okay. For those of you that work in a hospital setting or have worked in a hospital setting and kiddos have come in and the parents are saying, hey, you know, the kiddo has a fever. What was shocking about all of that, if anything? Or what did you find surprising? So the baby had a fever, but the baby was bundled up.
18 layers, 7 onesies.
So all the extra clothing creates more heat. So when the baby or whoever, if they have a fever, even if it's slightly elevated, things you can do is remove all those extra layers, their t-shirt, you know, any bottoms they may have. The most they should be in is a onesie or just a diaper. Does that make sense? So just some food for thought about that. When I did triage, it never seemed to amaze me that the baby had a fever, but they had the baby looking like they were about to go into an igloo. I was like, what is going on? So what about elderly people? As they get older, what's happening to their thermoregulatory system?
It's deteriorating.
It's deteriorating. So if you have an elderly, and this is not uncommon, elderly folks, their temperature may not be a reason to, or an indicator, not a reason, but it may not be an indicator that they have a serious medical condition like pneumonia, or they have a serious condition like a urosepsis. Okay, so that'll be something from the urinary standpoint. Because what ends up happening is they won't have a fever. So they can actually have pneumonia and be afebrile. Or they can be afebrile and still have like a urosepsis. Okay, so a lot of times we'd be looking for that fever to help us, you know, identify that they have an infectious process. For elderly, that's not the case. So things that you want to pay attention to is if you have an elderly person and they come in and they're confused, the two things you should be thinking is either they have pneumonia or they have urosepsis. Does that make sense? Anybody out there?
Yes.
Okay.
Yes.
So they have a diminished febrile response to illness. So you can't say, well, you know what, they don't have a fever, so they probably don't have pneumonia. More than likely they have pneumonia because they're not going to have the fever. But if they're confused, those are the places you want to look first. So confusion in elderly, either pneumonia or a urinary tract infection or urosepsis. Okay. So the highest priority for somebody that has hypothermia, because we talked about, you know, fever, so now we're going to go the other side. So if they have hypothermia, what do we want to do? What thing, and this is how does heat transfer? So we want to, if they are in the water or they came from water, meaning they were in a lake or something like that, we want to remove all that wet clothing because the wet clothing prevents them from warming up. It keeps them cool. And if they already have a low temperature, this won't be helping. We could look at rewarming and supportive care for them. Would we use a heating pad?
No.
Nope, we're not going to use a heating pad. We're not going to give them warm IV fluids. We're not going to do anything like that. So we're going to do that rewarming process, get the temperature up, blankets and things of that nature. But things to keep you from maintaining your heat is, you know, even if your sleeve is wet, you'll notice the difference in your temperature. So with low temperature, and we've actually already talked about this, but what other exemplar would you consider with a low temperature? And this has to do with the immature hypothalamus.
Hypothyroidism?
Hypothalamus is the one, that's the thermal, I'm sorry, let me correct that. With hypothermia, we're thinking about the immature thermal regulatory system. That's what I wanted to say.
Oh.
So with hypothermia, we're looking at the immature thermal regulatory system of the kiddo, okay? And then we're gonna look at things that can affect the thermal regulatory system. So we talked about low birth weight babies, and what else? What was the other population of babies?
Preterm.
Preterm or prematurity? Okay. If your patient, go ahead.
Don't some drug exposure, in utero drug exposures, cause thermal issues when they're born or put them at risk for it?
Are you talking about like cocaine or?
I'm not sure about specifics, but I know that we've had some kids that have thermal regulation issues from, and all I saw on the chart was in utero drug exposure. It might have been secondary to birth weight because of the drug exposure.
Right, if they don't grow. But there are some illegal drugs that, or some of it may not even be illegal, but your antipsychotic meds that can cause hypothermia. I think it's like the crack or or not crack, like meth that may do that. Like your ecstasy. That's along those lines.
Yeah, something. It might have just been because the drug use caused prematurity, which caused poor thermal regulation. So I don't know if it was that chain or if it was a more direct cause of the drugs.
Right. Yeah, there is a relationship, but it could be because if they're on those drugs, they're not well developed. So that part, yeah. When can you take a temperature on a patient? What if they just drank a hot tea?
30 minutes.
How long you need to wait before you can do an oral temp?
30 minutes.
Actually half of that. So 15 to 20. When you are hospitalized, how does that affect your muscles and all of that? Are you up exercising?
No.
Nodal atrophy.
So yeah, you'll have some atrophy that actually happens, and you know your body just kind of becomes more weak, and you don't have to be hospitalized for this to happen. Just FYI, you can literally be at home with the flu and just be sitting on your couch. And when you get up and you go to the bathroom, you're like, oh my gosh, you know, you feel like you're weaker than what you were when you were, you know, a couple of hours ago. So because of your immobility, you know, your body feels a lot more weak as those muscles start to atrophy. So it can cause the muscle or loss of muscle mass and strength. What is the medical term for that? When you have that loss of muscle mass and strength?
Is it the disuse syndrome?
Not that one. It does start with a D though. So when you have immobility and you start to get that atrophy of the muscles, what is that process called? Deconditioning is what that's called. So, yeah, that's why you feel, because you're not conditioned to get up. You've been laying around, not moving because you don't feel good. Let's see. If you have a patient that, and this is with mobility, so there's different pieces to it. What if you have a patient that has, they've had a stroke and they've lost some of their motor function? How do you treat them? Do you tell them, hey, well, you know, you're not going to be able to walk like you used to, so why don't you just go ahead and get a motorized scooter to get around? Would that be appropriate?
No.
Okay.
Do physical therapy.
So what should you do? What would be the best thing to do? I mean, because you have just as much stake in this as the physical therapist.
Promote safety, maybe low bed, fall risk.
All that, yep. And what else? So this is more about the patient. So if a patient has a stroke, or if they lose some type of functional ability, it's not the same as it used to be. Do you just be like, well, this is your new you? Or do you try to encourage them to do as much as possible with their limitations?
You encourage, and also patient teaching on loss of mobility.
So do you focus on the negative, or you keep it more positive?
Keep it positive.
So you keep it positive. You don't have to point out the limitation. Trust and believe, they already know it. So what you would want to do is encourage them to do as much of their self-care activities as possible. So within their limitations, but to say, hey, let's try to get you to the best, you know, to the best use of your arm, your leg, or whatever, to your ability. So when I did a conference in Kentucky in November, there was a guy that they brought on stage, and this was for the Organization of Associate Degree Nurses. And the kid, he was a very bright kid, but had a motorcycle accident and injured his spine. And they basically said that the kid wouldn't walk, he wouldn't be able to talk, etc. He just didn't take that at hands down. He literally fought, cat clawed, however you want to put it, but he literally dug in deep. He's not walking. He is still in a wheelchair, motorized scooter and all that. However, he has very good use of his upper body for sure, and he has feeling in his feet. So just think if he had just given up. And a lot of people were basically saying, you know what, you might as well just look at the new you. This is the new you now. But I mean, very nice young man, driving and the whole 9 yards. So basically, no matter how grim it is, you want them to at least be able to have as much functional ability as possible. So don't, go ahead and start them out saying, well, this is the new you, too bad, too sad. Don't do that, okay? So you want to have them do as much as possible. If you're looking for, if you have that immobilized patient, then you want to make sure you're doing that Braden scale to check the skin, make sure, we're not getting any skin breakdown or anything like that. So that's part of our nursing action. For that same immobile person, there's all types of assistive devices that can be used to help them move themselves up or pull themselves up in bed. So that way you can also save your back. So that's part of that, having them do as much as they can do within their limitations or within reason. For elderly people, you want to assess them for fall risks and, check their gait and see if they're a potential to fall. Pardon me. Knowing what types of either devices or things that patients can do to help minimize falls, like, making sure the rooms are well lit. You have slip resistant rugs, good support for shoes. You don't have a bunch of clutter, or they don't. Take out area rugs, because those things, even if they don't slip, they bunch up and then the patient ends up falling over it anyway. So staying away from those area rugs is actually perfect. Let's see. How do you know if someone has osteoporosis? What do they lose first? Or where you may suspect that they potentially have osteoporosis. So if they were 5'9" and now they're 5'7", is that something that's normal? Does that happen to people?
It happens to old people.
But they're losing their height. So that means that they may have some bone density issues. So that loss of height is kind of one of those measurable signs for folks. And what if they're not elderly? What if they're middle-aged? That's not normal.
No.
Okay. What types of food what nutrition for patients with osteoporosis? What kind of food do we want to tell them to eat?
Foods high in calcium.
So things that are high in calcium, like skim milk and yogurt, so anything with that would be perfect, right? Okay. What if, so say for instance, you have a patient that had osteoporosis and they fell. What type of assessment would you do?
Range of motion?
I wouldn't say range of motion, but there's something similar you can do. It's more like checking if they have a sensation in the extremity that was injured. Do they have pulses in the extremity that was injured that's palpable? Do you notice any swelling, any deformities, any bruising, any bleeding? Those are things you want to be looking at. things that compromise their neurovascular status in that injured area, that injured extremity. Have you had enough? Are you over it? We have about 17 more minutes.
I didn't realize my mic was on. I'm sorry.
Oh no, they're fine. So let's see. I think the only thing we haven't talked about is like coagulation, DVTs versus arterial clots. And so what if your patient is on anticoagulant or a coagulation modifying drug? That's what they call them now. Coagulation modifying drug. So what if your patient's on that? Then what kind of teaching are you going to tell them? So they say they had a clot and we put them on some type of coagulation modifying drug. So what are some things we're going to talk to them about? What's going to be our teaching?
Not to take aspirin. Monitor.
Well, aren't they? They're already on a. They've already put them on a medication, so they coagulant to go home on.
Try to avoid any sort of injury, any trauma.
So avoid trauma. Okay. We know it caused bleeding, so what do we want to tell them to look for? Bright red, like bleeding gums, hematuria.
Tell them to watch for stool changes that indicate bleeding.
Yep, stool changes. Should we tell them to move around?
Yes.
And if they're sitting for any long periods of time, they should do those chair exercises. Know the risk factors. They should walk daily. So there's a lot of different things that we can talk to them about. If they're up and they're moving around, then that keeps the venous blood circulating. But if they're sitting down, then you're gearing up for a clot. What if a child with hemophilia gets injured? So, what's the treatment for injuries?
Factor.
Say that again?
Clotting factor.
Okay. But what else? What if it's an extremity?
Direct pressure.
Not pressure, because remember the bleeding's it's internal, not external. You just see the bruised color. So say for instance, if it's the arm that's all bruised up and you can see the blood collecting underneath or whatever, what can you do for that extremity to assist? Elevate it. What else?
Cold pack.
You can do ice. So what's that mnemonic?
Rice.
Rice. So rest, ice, compression, and elevation. So questions for me. I don't know if this, I hope this helped you. We'll see.
Yes.
So I tried to go through all of the exemplars and then cover the ones that we didn't get to in class, but hopefully you guys are, just because we didn't get to it in class doesn't mean you're not responsible for it. So I want to make sure we're clear on that. Even with the extra time, we're going to still find that we're going to run out of time on some things. So you should be doing all of your exemplars accordingly. And so this one is kind of a heavy hitter, which is why we gave you the extra week. And that's because I think you have like 7 exemplars, if I remember correctly.
Yeah, it's 7.
Yeah. Oh. Okay. All right. I mean, if you have, we have about 13 minutes now. We had 17. Now we have 13. If you're roasted and toasted, then we'll see you tomorrow at 9 P329. So 30 minutes later. So we're going to go ahead and move on to gas exchange. We're going to talk about that. In your, I don't know if you have this, but there's an article that talks about COPD. It's a very good article. And anything you ever wanted to know about COPD, it's in there. That'll be a good article to read for you to have a good, clear understanding about it. And we're going to talk about, the peak flow meters, and we're going to talk about the FEVs and what all that means, and for your patient, and how do you help them, etc. So be ready for that. I have a little exercise for you guys to do, work in groups. So, questions?
No, ma'am.
Nope.
All right. Well, we're going to sound off 12 minutes early. If you have a question, just ask it tomorrow when I see you. Other than that, we'll see you then.
Thank you.
You're welcome.
Thank you.
Thank you.
You're welcome. You're welcome.